Good morning. Hope everyone's doing well. I'm happy to be here to do these sessions. I'm sorry I'm late. Some kid issues, trying to get the kids to school, negotiating terms, and all sorts of things like that. In any case, I'm going to start by delving into some of the questions. The first question is from Cindy Niles. Hello, doctor, and Happy New Year. Hello, Cindy. My gratitude for answering the answers you've provided. Many thanks. My real pleasure, Cindy. I'm 41 years old and trying to piece together a puzzle for which I seek your insight. If calcium and PTH have inverse relationship, why then would PTH remain perfectly stable despite calcium shifting by a whole milligram? 10.2 milligram per deciliter calcium reading in October and 9.2 in November, both return with a PTH of 33. In what context does it make sense? Background context, vitamin D is 21. I do not tolerate vitamin D supplements, but spent the sunny months at the beach without applying sunscreen. Oldest reading, calcium 9.7, PTH of 16. Highest reading, 2017, calcium is 10.3, no PTH checked. Next reading, 2017, calcium 10, PTH of 40. 2018, calcium 10.2, PTH of 33. Next reading, calcium 9.2, PTH 30. In this case of normal hormonal hyperparathyroidism, is this the case of normal? Why does the PTH show overt suppression? Could this be indicative of hyperplasia? Very good question, Cindy. Let me try to delve into it. So, let's see. So, let me flip you around. Okay. So, let's see if I can get this. All right. So, the relationship between calcium and PTH is inverse, of course. Normally, so when you have a low blood calcium, your PTH is produced by parathyroid hormone, which goes to your bones and tells your bones to release calcium, goes to your kidneys, tells them to hold on to calcium, not let it go in the urine, and activate vitamin D, right? And as the calcium comes up and you go to high blood calcium levels, then your PTH production is diminished, right? And the relationship between, the relationship between calcium and PTH follows this curve, right? And that curve is calcium on this side and PTH on that side, right? Anyways, this inverse relationship exists. Having said that, your calcium, your PTH levels change every few minutes. The reason for it is whatever PTH you produce at this moment in time, so whatever I've produced right now, in 5 minutes, half of it disintegrates, right? So if I have a slight change in the direction of calcium, right? Then, so for example, if all of a sudden I'm doing something today where let's say if I go for a long run or do weightlifting where I put pressure on the bones and the bones that are now trying to remodel and re-strengthen, they are going to change their absorption of calcium. And in doing so, they're going to create a quick shift in the calcium that they're grabbing out of the bloodstream. And it may not translate to a complete drop in calcium yet, right? Because calcium movements can take much longer period of time to occur, right? In terms of the bloodstream. But the parathyroid may detect a shift, a change in a direction and produce hormone in response in anticipation of something going on. And so sometimes you'll get the same exact PTH levels at a different calcium. That doesn't mean that it doesn't mean anything in and of itself, because it could be reflective of a very sensitive system looking at changes and anticipating a response and producing PTH in response to it. So the fact that you had a calcium of 10.2 and a calcium of 9.2 on a different occasion with the same PTH levels is not alarming in any sense, okay? That does happen. And that's the problem with the parathyroid system, is that if you want to make a judgment on the system based on one data point, you can oftentimes be misled, right? Because when you have a calcium of 10.2 and a PTH of 33, that in and of itself seems appropriate. Calcium high, normal. PTH towards the lower side of normal, but not low, right? And so you have to look at the patterns, and that's what I keep saying. You know, some patients who have hyperparathyroidism, I think, in fact, just based on a Canadian study, a third of the patients who have hyperparathyroidism have classical hyperparathyroidism. Only a third, where they have high PTH and high calcium. Calcium of 11.5, PTH of 250, easy peasy. Anyone can diagnose that, right? But that's only a third of the patients. The majority of patients have normal calcemic or normal hormonal, and some patients have both normal calcium and PTH, and the only way you figure out that they have hyperparathyroidism is by looking at the pattern and the relationship between calcium and PTH consistently. Now, going back to yours, so, you know, looking at your numbers historically that you've given me on your email there, I don't see a pattern that tells me for sure you have hyperparathyroidism, because you have PTH levels that are anywhere between 16 to 40, right? And calciums that can range anywhere between 9.2 to 10.3, right? And so you fall in that category where your calciums are in the normal range, your PTHs are in the normal range, and we are trying to figure out what problem you have, and the numbers are not painting a clear picture. I'm not saying you don't have hyperparathyroidism, I'm just saying your laboratory numbers are not very clear. And that patients such as yourself are especially challenging, because you make the diagnosis based on looking at the whole person, right? So if someone like yourself, you're 41, if you did a bone density study that showed that you have osteoporosis, for example, and I saw a patient yesterday like that, late 30s actually, with osteoporosis, numbers very similar to you, not making any sense, right? For this person this young to be having osteoporosis and have fractures. But nonetheless, the calcium and PTHs were in the normal range, but they didn't make perfect sense because they didn't always have a suppressive and upon doing imaging, and this is the only time where I depend on imaging studies to help direct me as to diagnosis and course of treatment. By that I mean, when the numbers are not clear and you have symptoms that make me feel that this person has hyperparathyroidism, the imaging study, if they show clearly enlarged parathyroids, that gives me enough reason to proceed. You know, otherwise, if you have these types of numbers, you have symptoms that go along with it, but you have nothing on the imaging study. You're unfortunate in that you may have hyperplasia and none of them are enlarged enough to be visible on any of the scans, then you're kind of in a tough situation, because in order for you to do a surgery, it takes a leap of faith, in a sense, to proceed, because the numbers, the laboratory is not showing it, and your imaging studies aren't showing you a target, and you're basically going on your assessment of the patient, right? And these are the patients that are tough, because they are having so much trouble. I mean, their life is so affected, and what you do is you do your best to try to figure the story. You become in a sense, an investigator, trying to figure this out. And oftentimes what I do in these situations is, if the imaging study is negative, right? If I don't see a clear target, I have them look historically for calcium. So if, Cindy, for example, you have calciums you had it from 2014, which was 9.7 with a PTH of 16. If you have calciums from a decade before that, so in 2004, 2005, 2006, you had calciums that always ranged between 9.1, 9.2, 8.8, 9.1, 9.2, and now you're hovering at a higher number, then that's also an indication that something's going on, and now you're hovering at a higher number above what you would what would be appropriate for your body. So you are in a tough situation, and you're asking if this is normal hormonal hyperparathyroidism. I don't know how to label this because I actually don't know what you may have. I mean, if you've gotten so many PTH levels, I'm sure you're very symptomatic, and that's why you're pursuing it. And I think really the only next step for you is to do an ultrasound, see if you see. If that is not fruitful, do a 4D parathyroid CT scan, see if you see a target. And if you do see a target, then that's more reason to take action. Now, if you have hyperplasia, then you're gonna have to find a surgeon who'd be willing to commit. You guys would have to have a connection and to explore your parathyroid and see if they can figure out. And that's a big, it really is, it's a big leap of faith. Again, it is. I've taken it for patients, and fortunately, my patients have been appreciative. We've had good relationships, and it has worked out because, you know, it's a bidirectional risk. A risk the patient is taking in performing, going through with a surgery of uncertain result, and you know, a risk by the surgeon in a sense because they're doing a surgery when they're not certain if the diagnosis is clear, and that's a tough one. So that requires a huge bond between you and your surgeon to try to figure out what the appropriate course for you would be. That's like Cindy, but I look for historical data, and my advice is, and also do your imaging studies to see if you can find a target. A long-winded answer, but it's a tough one. You had a very good question and a tough one that we see a lot of times, unfortunately. Hi, Dr. Larian, Kim Cornett Buck. I have secondary hyperparathyroidism after 2 glands, 1 adenoma and 1 bad. Not sure what that means. Were removed in January 2014. Unfortunately, the remaining 2 glands do not produce enough PTH. I started Nat-Para in July 2017. I'm currently on 75 milligrams once a day. I also take 400 milligrams of magnesiums 2 times a day to control muscle twitches and spasms, 2,000 units of vitamin D3. I try to avoid supplementing with calcium after taking too much a couple of years ago prior, and ended up in the hospital with a calcium level of 13 and acute renal failure. My most recent labs before Nat-Para injections are serum calcium of 8.9, albumin 4.7, vitamin D 29. Corrected calcium is 8.34. Question, is only testing serum calcium sufficient, or should I always have albumin tested for corrected calcium level? First question, I think, you know, just looking at your own numbers, your calcium was 8.9, and after you corrected it, it went down to 8.34. So you have a great disparity between those 2 numbers. And I think for you in particular, looking at the albumin, either getting albumin or getting ionized calcium, so that you can get a more accurate picture of what your calcium in your body is, right? Ionized calcium is problematic only in that the machine that tests for it has to be calibrated well. So the place where you do it, they need to be doing it all the time, and they need to be on top of their game, making sure their machines are working properly and calibrated properly. But if you get albumin, then you can do the calculation, and that's easy to figure out. I am 55 years old and work full-time as an IT manager. And most days I feel so tired. I'm not sure my doctor really hears me when I say that because I look healthy. I have an appointment on January 21st. Is there something else to test? Should the Nat-Para be increased or even split dosing? Thank you very much for your advice. Well, first and foremost, Kim, actually, my advice to you is to split the Nat-Para dosing to 2 a day, for sure. We know for a fact that PTH level variations are important in allowing bones to heal. When patients have hyperparathyroidism and they have a constant elevation in PTH without variability during the course of the day, the bones don't have an opportunity to resorb and then rebuild. So these variations in PTH levels allow resorption of bone, and then when you have a downswing, creation of bones. And so this cyclical pattern actually is important. So I think doing it 2 a day is more important to get closer to the physiology of the system. And, you know, and potentially that maybe even more changes that need to be made to get you in balance. I'll have to look into that more and talk to the people who use Nat-Para a lot to see what's the latest data on it. Um, but I think definitely splitting the dose is important. Now, your vitamin D is on the low side. I know you're taking replacement and that's appropriate. Maybe increasing your vitamin D replacement, and instead of taking calcium supplements, having a lot of green leafy vegetables so you get it through your diet during the course of the day and you're not getting in massive doses with pills. That may be something else that can help you out, because obviously your body is designed to get things through natural paths anyways, you know, rather than pills. So if you can follow that path, you know, ultimately you're the one who's going to be able to fine tune this system. I think your calcium is probably too low if you're feeling fatigued all the time. So you need to increase your calcium, but I think trying to do it through dietary means rather than supplement means would be a better way to go. All right, best of luck, Kim. It's a tough situation. Yeah, hyperparathyroid, it is a really tough situation, and you know, I have unfortunately a few patients who have it. You know, it's when you treat hyperparathyroidism enough, you're gonna get. You know, I have 2 patients who have it, and you know, I feel I wish I could do more for them. You know, I wish the situation, parathyroids are tough, but conditions, tough surgery, tough treatment, and you know, the inconsistency in how the disease presents, how many parathyroids are abnormal, how many parathyroids you have, 3, 4, 5, 10 parathyroids. You know, there's so many nuances, and they hide in all sorts of places, ectopic places. Sometimes you find them, sometimes you don't. Sometimes you are looking for them, don't find them, but the process of looking for them causes blood vessels to not function properly, and it's hard to predict how that happens. I mean, it's a tough situation, and it does happen, and so I feel for you, I really do, and I wish you the best of luck. But I think you, more than anyone else, will be able to fine tune this, because you're going to be the one who is going to figure out how to supplement yourself, hopefully through natural ways of eating foods and stuff with high calcium, and splitting the nat para, changing your vitamin D supplementation and so on, and trying to get, you know, with the vitamin D supplementation, you increase your vitamin D supplementation, you absorb more calcium from your foods. So I think that's probably a better way to go. All right, best of luck. Susie Q. Barker. Is it correct that an otherwise healthy, no medications other than vitamin D, but symptomatic patient in their 50s with a diagnosis of hyperparathyroidism should be excluded automatically from parathyroid surgery due to age unless they develop bone fractures or kidney stones? Is it correct that kidney stones and fractured bones are the only symptoms of You're asking the most quintessential question, but I'll explain why I say that. Is it correct to take the watchful waiting approach to hyperparathyroidism when the patient has a calcium 10.7, inappropriately normal PTH vitamin D 1 point above deficient on the high end of normal when hypercalcemia started, and symptoms that are not bone fracture or kidney stones? DEXA scan normal, 24-hour urine normal. Should an ultrasound of the parathyroids be done at any time before excluding a patient from surgery? Should the exclusion be made via kidney ultrasound in patients with no symptoms or signs of bladder kidney stones? I'm curious to know why kidney ultrasound would be done instead of imaging the parathyroid area. I laugh because I have the same concerns as you. I've read that up to 85% of patients with hyperparathyroidism do not develop kidney stones, so I find it odd that it would be the determining factor, must have, in permitting surgery. Thank you, Susie. This has been haunting parathyroid patients for a long time. The reason for this is that the symptoms from hyperparathyroidism are quite vague. You know, fatigue, memory loss, moodiness, impatience, sleep changes, palpitations, going to the bathroom frequently, urinating frequently, and constipation, acid reflux. None of these are very specific, but as a collective, they are devastating and they have an impact on the quality of life, which is immense. So when patients don't have the clear-cut symptoms that are associated with hyperparathyroidism, by that I mean kidney stones, osteoporosis, or bone fracture, the other vague symptoms are generally by endocrinologists not considered to be adequate enough to treat. The reasoning for this is that ever since 1970s, when these laboratory machines have come about, testing for calcium and PTH has become, calcium specifically, has become more common. And ever since they come into the picture with the annual exam, people have checked calciums. And when the calcium started going up, the doctors didn't know how to address it, right? They're like, okay, well, before we used to treat hyperparathyroidism when people had the achy bones, psychic moans, stomach groans, and kidney stones. Really, this is the basic mantra of hyperparathyroidism that people were working on in the past. But back then, before the 1970s, when someone had hyperparathyroidism, they either became psychotic because they had such high calciums, or they had bone fractures all over the place, or they were passing meds to that effect before they were treated, right? And then after 1970, all of a sudden we're getting all these people who have elevations in calcium and don't have those symptoms. Well, that's because you're catching it before they get there, right? So this consensus group got together. It's an international consensus group for treatment of asymptomatic hyperparathyroidism. By asymptomatic, they mean patients who don't have bone fractures or kidney stones, right? And the reason they call it, they don't consider the other symptoms as symptoms is because they looked at the research studies out there, trying to figure out if treating hyperparathyroidism affects the other symptoms, right? So, and there are just as many studies out there that show that if you treat someone who has hyperparathyroidism, their fatigue doesn't change, as there are studies that show there's quite an improvement, right? There's just as many studies showing that mental issues, depression, anxiety, or memory issues, just as many studies showing that there's no improvement as there are studies showing improvement. And so what they do is this consensus group gets together every 4 or 5 years, right? And they go through the latest data and try to figure out what other things should be used as an indication, right? And because the studies are, it's hard to study parathyroid patients and these symptoms because it's hard to score a symptom of fatigue. It's hard to score some of these factors. And there's been no study out there that shows, okay, yes, this patient has had hyperparathyroidism for 30 years, right? We discovered it when she was in her 50s, right? Clearly she's been having it, looking at her symptoms, looking at her laboratory. She's had it for 30 years, right? And yes, if we do surgery on her symptoms, they do surgery on this person, let's say, and they say, oh, well, she continued to be fatigued and she's continued to have memory loss. Well, the parathyroid surgery didn't help her. But I feel that these studies are short-sighted because they're only looking for improvement, right? They're not looking for halting of the progression of disease, right? And that's one of the problems we have today is that we have this notion that we as healthcare providers, our role is to cure, right? Not necessarily to halt the progression of disease, not necessarily to allow the person to have progression, stop the progression, have the opportunity to improve their body, improve their physique, improve their mental status once they have an opportunity to not fight the disease, right? So yes, it's very likely, and I tell patients, your symptom improvement has to do with how long you've had this disease, how far away you are from your natural calcium levels and PTH levels, right? And how long you've been in that state. Because, let me give you an example, high blood pressure. So hyperparathyroid patients oftentimes have high blood pressure. This happens through two mechanisms. One mechanism is calcification of the blood vessels and stiffening of the blood vessels, so the blood pressure increases. The other mechanism is the effect of PTH on the adrenal glands, which produces a hormone called renin, and renin-angiotensin system, this hormonal system, can affect blood pressure. So if your blood pressure is elevated because you're producing extra renin-angiotensin, that pathway is affected and your blood pressure goes up. When you do parathyroid surgery and that goes away, your blood pressure comes down. But if the blood pressure issue is because of calcification of your blood vessels, right, you're not going to get decalcification of the blood vessels where there's been deposits of calcium in the blood vessel for 20 years. That's not going away. But what you do have, you stop putting more calcium in those blood vessels and stiffening up even more. So you stop the progression of this disease. Is that valuable? I think I really do see that as a value. If your blood vessels are stiff and your blood pressure is now 140/90, not good. But it is much better than 5 years down the line getting a blood pressure of 190/110. So yes, sometimes you don't have the impact that you want. You don't have complete correction of symptoms, but you halt the progression of disease. And so I find this thinking that you have to have bone loss or osteoporosis or fracture or kidney stones as the only thing, because the data is not out there, as short-sighted. Now, having said that, this consensus group that never comes out and says, you're making a mistake doing a surgery if you don't have kidney stones or bone fractures. They say, in our opinion, the indications for treating hyperparathyroidism are definitively clear when you have a bone fracture or osteoporosis or kidney stones. They never say that you should absolutely not treat a patient. So Susie, if your doctor is telling you you should absolutely not do it, and you know the quality of your life is compromised because of this disease, I strongly urge you to make your point that your quality of life is more meaningful than anything else. That age of 50 that they've chosen is completely arbitrary. And so let me try to show you the guidelines as they are today. All right. So these are the guidelines from the International Workshop on Management of Asymptomatic Hyperparathyroidism, right? 1990, they said your calcium needs to be anywhere between 1 to 1.6 above normal. Then 2002, they changed to 1, and it has stayed the same since the last group got together in 2013, right? The number 1 above normal is completely arbitrary. There's absolutely no scientific paper that shows that number means anything, okay? And those of you who have normal calcium hyperparathyroidism know that to be true, right? Bone density loss, it was negative 2.0 Z-score, then they switched to the T-score, and it's just definition of osteoporosis, except that in 2013 they said, well, bone density studies are not fantastic in showing the vertebrae, right? So you should do a CT scan, MRI, or a specific bone density study for the vertebrae to figure it out, because the DEXA scan is not accurate enough in the vertebrae, and you may have fractures in there and it may not show it, right? So you have to do more studies. You have to do CT or MRI of your spine. Then your kidney function, and at some point they said 24-hour calcium is meaningful, and then in 2008 they said it's not meaningful, and then now it's meaningful again. But in addition, you need to do a urine stone risk analysis of the urine to see if your urine shows that you have a higher risk, even if you don't have a stone, if you have a risk of stone. And then you need to do ultrasounds and stuff. These are the recommended guidelines. And the age above 50, right, is based on life expectancy data that came out in the 1960s and 70s, right? Maybe even older data that said, people's life expectancy is, around the 70s, right? Which is not the case today. So, if you're 50 years old, you have only another 20 years to live, God forbid. And so we'll let you go. Hey, something else is going to kill you with parathyroidism, right? And that's not correct thinking. And this number is arbitrary. So if you're a 51-year-old, you have osteopenia, right? If you're a 51-year-old, 3 years from now from me, and if I have osteopenia, I'm going to wait for my bone to fracture before I do it, or am I going to do something about it before it gets to that point? It's madness to think otherwise, right? So I encourage you, if you have symptoms that affect your quality of life, to take action. to say to your doctor, I'm sorry, I understand what you're looking for. You're looking at those guidelines, but you don't know how I feel, right? And I don't want my symptoms to progress, and I don't want my bones to loss to occur, to progress. I want to be as healthy as I can be, right? And I choose to have surgery if I can find the abnormal parathyroid at a minimum. So I want to have an ultrasound on my neck, and I want to pursue it. And I think that's where it's your body. Your doctor doesn't get to decide how much your disease is affecting you, right? You get to decide the impact and when you want to take action. No one else should. Absolutely not. All right, moving on to the next question. Now, Susie, in closed systems like an HMO system or the National Health in England, they may stick to these guidelines more so they would in other healthcare systems. And so if you are not part of an HMO or thing, you have more of a voice. But even in an HMO setting, in a national health setting, I think if you sit down and emphasize my symptoms, my life, my choice, you just have to be very proactive and fight for yourself. You have to be your own best advocate. All right. Crystal Uribe. Hi again. I'm currently over 10 months post-op. So far, all blood work remains normal and left with only 2 glands. After second surgery, calcium dropped too low, 6s, and ended up in the ER. Took months to go back into the normal range, low 9s and 8s since March 2018. However, I'm not sure how much calcium and vitamin E I should be consuming daily as far as supplements. Only reason I still take it is because I went a few days without it, and any calcium twice for some reason started getting light tingling and body twitching. My endo didn't think I had anything to do with my calcium since she stated it shouldn't still be fluctuating since it's been almost a year. What are your thoughts about this? My thoughts are that every body is different. Every physique is different, and if you had 2 surgeries, it is possible that the remaining 2 glands were the vascularity, the blood vessels going to those 2 remaining glands, were somewhat affected, so that instead of getting 100% of the blood flow, maybe they're getting 80% of the blood flow, so they're not optimized, And when that happens, and I think that's a real risk with the parathyroid surgery, especially when you do bilateral exploration, you can compromise the blood vessels feeding it. And so when you have a second surgery, right, and you affect those blood vessels even more so, they could be not working at 100%. You could be having parathyroids that are working at a fraction of what they should be doing. So your calcium PTH numbers are meaningful, right? And I think, Crystal, you are the one who's going to be better able to figure this out than anyone else by continually checking your calcium and PTH. And I suggest for you doing it every couple months and checking and adjusting your calcium intake and keeping a diary of your symptoms, because although in the ideal circumstance, yes, a year later you should be totally fine, that's not necessarily always the case. And I do have a few patients who, although they have calciums that are in the low normal range and PTHs that are there, they feel bad, and when they take calcium they feel better, right? When I can transition to natural sources of calcium, I always find that they do better on that. So I think you're on the right track. You just need more data points to figure out where your supplementation should be. All right, so more from Crystal. I switched vitamins twice. When I started to take the multivitamins instead of just calcium supplements, for some reason I always get random heart palpitations or flutter, which I never had before. I had all the tests done on heart and all back normal. Well, when you take multivitamins, the dose of calcium and vitamin D is less, so you're not probably getting as much, and it makes sense that if you have either too low a calcium or too high a calcium, you could get flutter. And then you ask if you could be taking too much. I mean, yes, when you take multivitamins, then you run the risk, if you're taking a lot of them, you run the risk of taking something else that goes out of whack. And yes, just like you said, the multivitamins don't have a lot of calcium in them. Last time I ran out, I remember having some symptoms, but I assumed it was something else. Last checked, month ago it was 8.8 and all my blood work is all normal range. Could the new range of calcium cause random heart flutters? If so, does this mean I have to take calcium vitamin E for the rest of my life? More than likely. I mean, it's been a year, so you can still have, we heal. We continue to heal even after a year. So you may have improvement in the functioning of your remaining parathyroids in the next coming years, but I think you really need to continue to monitor so that you can make appropriate, judicious decisions about what supplementation to take. I oftentimes find that patients who have these changes in calcium and with taking magnesium, they do a little bit better. So you may want to test drive taking magnesium supplementation at the same time, going to natural sources of calcium, having a serving of cheese every day, which has vitamin K2 in it, so that helps absorption of vitamin D, spreading out the dosing of your calcium and vitamin D to twice a day or maybe even 3 times a day to get a more even concentration of those things in your bloodstream. Good luck. Colleen, Happy New Year to you and your colleagues. Dr. Larian, thank you, Colleen. Colleen Jackson, I have attached the pathology report for my parathyroidectomy I had in September and the bulky parathyroid gland that was removed. At my 4-month follow-up appointment last Tuesday, my endocrinologist suggested I may have foregland hyperplasia. I know it's rare, but research by Sally Bali and Charlotte Damon, fellow members of the UK Hyperparathyroid Action for Change, suggests it possibly could have been a lipoadenoma that was removed. In your last one, I waited 6 months post-op to see if I was cured, but since I have received this possible diagnosis, what do you think I should do now? Your advice would be most welcome. Thank you in advance. All right, let me look. So, the parathyroid is tissue composed of sheets of chief cells, cells interspersed with abundant adipocyte. This may be normal parathyroid tissue or tissue from a lipoadenoma. There is no evidence of malignancy. There is specimen, okay, all right. So the conundrum that you have is, where do you stand, right? And I think, let me try to say, so parathyroid pathology is hard to determine because when you have hyperplasia or when you have a parathyroid adenoma, the actual cells under the microscope look the same. So these are parathyroid chief cells and these are fat cells. The white blobs in there are fat cells. A normal parathyroid has an abundance of fat cells interspersed between the parathyroid cells, right? Which is why parathyroids can oftentimes be hard to find because they look like lumps of fat with a slight change in color, like a slight strawy discoloration that can distinguish it. But that comes with experience. In any case, so there's a lot of fatty content. A lipoadenoma is an adenoma that has a lot more fat in it, right? But how do you make that diagnosis? It's very challenging to make a diagnosis of an adenoma, being an adenoma while having fat, all right? And I'll tell you how that can be done. Now, an abnormal parathyroid, here you'll see an abnormal parathyroid has a lot more cells. Again, the cells look exactly the same. This is just a different color dye, which is more purplish, right? But the cells look the same, right? And less fat in between, right? And so there's a gradation between this and this, right? And every individual is different. So I may have a lot less fatty tissue in my parathyroid because of my genetics dictates that way. And my brother may have a lot more fat, and that may be just our baseline. So it's hard to look at this slide and say, well, this is clearly abnormal and this is clearly normal. You can't say that because your baseline can be different, right? The only way that you can have a definitive say is, well, if you don't see any fat and you see all these, then that's probably an abnormal parathyroid. So if you get this picture, right? Only this part, and there's just no fat, you can say with certainty that's abnormal. Or if you have a parathyroid adenoma. A parathyroid adenoma has areas of cells where there's no fatty tissue or very little fatty tissue like this, and a rim of normal parathyroid where there's parathyroid cells and a lot of fat interspersed in between them, right? So when you have this concentrated nodule of parathyroid cells and a rim of normal, then you can say this is a parathyroid adenoma. So if you have a lipoadenoma where this area, right, has parathyroid cells and a lot of fat, some degree of fat, and then adjacent to it you have this picture where you have a parathyroid area where there's a lot more fatty tissue in there, and clearly there's a separation of this area from that area, then you can say this is an adenoma with a rim of normal parathyroid tissue. That's the only time where you can really be definitive, okay? So the first and foremost, that. So pathology and pathology reports can oftentimes be not so informative, okay? And so you have to take, that's why in the operating room, when we do frozen sections and the pathologist says, you know, I see an abnormal parathyroid. I question, why do you say this is abnormal? Well, there's not a lot of fat in it, okay? Do you see a rim of normal parathyroid adjacent to it? If they say no, then all I take from what they're telling me is you have a parathyroid. You've biopsied a parathyroid. That's about it. Nothing else. You can't make too many more decisions. I oftentimes go upstairs to the pathology lab and sit down while the patient's on the operating room bed and look at the images under the microscope to compare, you know, if I've biopsied 2 or 3 parasites, to compare. So I can see under the microscope what they look. I can see in the patient what their parathyroids look like. I can look at the numbers, PTH and calcium levels, and kind of try to figure out, and then the rapid intraoperative PTH testing to guide me as to which ones to remove, you know? But it could be tough. And yes, you have an adenoma removed, right, that had more fat in it. They're calling it a lipoadenoma. They're not describing why they call it a lipoadenoma, but they just say it could be an adenoma, it could be a parathyroid tissue with fat in it, or it could be a lipoadenoma, right? That's all they're saying in your pathology report. So you can't use that to see. And your endocrinologist is correct. It's possible that you may have hyperplasia because your numbers haven't corrected. But I think you really have to wait the full 6 months to see if your number is correct. Because if you have some degree of hungry bone syndrome that's trying to grab all the calcium out of your bloodstream, your parathyroid, or your remaining parathyroid would work harder to not let your PTH, your calcium level in your bloodstream dip too low, and that may give you a picture that looks like a persistent disease, right? And all it is a readjustment of your body. So I highly encourage you to wait that 6 months. Look at your calcium, PTH, and vitamin D numbers during that time period. Supplement appropriately, right? And see what your numbers get to at 6 months. And if your numbers correct themselves, then you are done. You're done with us surgeon types, you're done with endocrinologists, you go on with your life, avoid doctors at all costs, and have a good life, and not think about parathyroids ever again. And, well, do an annual exam and check them to make sure another one doesn't go sour. But that's what I would suggest. And if at 6 months your numbers are not correcting, you're continuing to be symptomatic, then you probably have persistent disease that may be hyperplasia, maybe another adenoma. And I'd say probably in a great majority of cases it is hyperplasia, because most of the failures that I have found in myself and other surgeons' operations have been in patients who have hyperplasia and one gland that's significantly larger than the others and overfunctioning more than the others. And when you take that one gland out, the other ones have the opportunity to manifest. All right, moving on to the next question. Colleen, Sally, Charlotte, thank you for your interesting questions. Thank you for keeping me on my toes. Terry Coyne, your number 1 fan here again in the UK. Hi, Terry. My last 4 lab results have been just within range for adjusted calcium and PTH with lower vitamin D, but still above deficient. Been supplementing 5,000 units daily for a 1.5 years with K2 and magnesium protocol. Great job. Tiny kidney calcification have not shown up in the last 2 ultrasound scans. That's good. Only symptom now is 7.8 bone loss in lumbar spine. No osteopenia yet, but low bone density there only. Previous DEXA 2 years ago was normal. Been postmenopausal for 3 years at age 56. Family history of osteoporosis. Do weight training and resistant exercise regularly. Hike, eat whole food, plant-based, no medication. Do you think my bone loss is normal, or could it be due as yet undiagnosed hyperparathyroidism? Terry, it's complex because you're also postmenopausal, and so the absence of estrogen also leads to some degree of bone loss. Now, when you say my last lab results are within range, again, I encourage you to look at the relationship that they have. If they're both within range, but they're both on the upper side of normal consistency, then you still have persistent hyperparathyroidism, right? But if they're following an inverse relationship in the normal range, then you've been treated appropriately. And the bone loss may be due to the menopause that's occurring. And I encourage you to continue to do your exercise and so on. And you're doing everything perfectly, but you just need to analyze the number and track the numbers to see if your parathyroid is still problematic. And I don't think you need to do a wait and watch technique. I think you just need to look at the numbers and decide, do you still have hyperparathyroidism or not? And the only thing that's going to tell you is your symptoms and the relationship of your calcium and PTH, okay? So good luck, Terry. Hopefully you still remain my #1 fan. Hopefully I've answered you clearly enough. And best of luck, dear. Teresa LaSalle. Question. I have had parathyroid surgery for 1 adenoma in November of 2018. I have a follow-up after surgery on January 22nd to look at the numbers. If numbers are good, I'm wondering now if I can take bovine powdered collagen. I had read there is calcium in it, but also that marine collagen has even more calcium. I'm not sure, truthfully, because I haven't really had patients who've tried to replace the calcium with collagen-based products. Having said that, why not? I mean, if there is collagen in the material, then you have enough vitamin D on board, then you're going to be able to absorb it. Beef, and you're asking if beef broth is okay. I'm not sure if creating the broth takes some of the calcium out of it or not. Again, if you're not having symptoms right now, right? And if you're done with your calcium replacement after your surgery, because it's been more than a month and a half, right? Close to 2 months since you've had, actually 2 months since you've had surgery. If you're not having symptoms, you're not taking supplementation, and your numbers look good. And I mean, if you had only 1 adenoma removed, I'm pretty sure your numbers will look good. Then I think getting your calcium any which way you can should be okay. I don't think you really need to overthink it, because, if you have enough green leafy vegetables in your diet, or have dairy, then you're gonna get enough calcium in your system, right? And I don't think you really need to worry about it too much, okay? And if you want to take the collagen at that point, just definitely take it. All right, Susan Korea, Happy New Year. Happy New Year, Susan. I've asked for your opinion before, several months ago. I'm 63, I've had been treated for Graves' disease with iodine 131 in 1980. I had 2 adenomas removed in June 2016. Numbers all came down in the OR. I have continuing high PTH anywhere from 89 to 150. Calcium is 9.5 to 9.9. I just saw a parathyroid surgeon at U of M, and he said it wouldn't be worth the risk for re-op to go through a scar tissue, possibly causing vocal cord damage, just to get PTH down a little, and risk of hypo-PTH. Also, it wouldn't guarantee it would improve my many symptoms and osteoporosis. I left there very sad and frustrated. Well, Susan, first, I don't agree with your surgeon, right? Because you're not trying to bring down PTH numbers. You're trying to address a disease that you have, okay? I mean, that seems to me to be thinking on a very limited or short-sighted basis, okay? We're not treating patients with hyperparathyroidism to make their numbers look good. We're trying to treat them so that they feel good, all right? And if you're not feeling good, again, yes, it's true that some of the symptoms don't necessarily get better with treatment with surgery, but you at a minimum stop the progression of symptoms, right? And so that's what you have to think about. If you were to stop the progression and you were to halt it here, compare it to, 6 months ago, a year ago, how much progression of symptoms are you having, right? And if you can stop the progression of symptoms, is that a plus for you? 1, 2, you have 2 remaining parathyroids, right? In order to treat what I would say is hyperplasia, more than likely what you have to do is they have to remove one of the 2 and potentially half of the other one, right? Yes, true. And what I would do is I would do imaging studies and see which one is visible and which one is bigger. If there is one that's clearly visible or bigger than the other one, that's the one I would remove. And during the operation, I would check parathyroid hormone levels. If your PTH levels come down, let's say you're starting at anywhere between 90 to 150. Let's take the number 100, right? If you remove one parathyroid on one side, take it out, and check your PTH levels, and your number goes from 100 preoperatively to 20 at 10 minutes and 18 at 15 minutes, then you know the last remaining parathyroid is not only functioning, which is really important, but also not super functioning, right? That will mean the end of your surgery, right? Because people who have hyperplasia, we cannot cure. We can offer a measure of control, because those patients who have hyperplasia, they have parathyroids that have poor control over duplication and growth, right? And these parathyroids keep continually grow, right? While patients who don't have hyperparathyroidism or hyperplasia have a parathyroid that grow during the times that you're a child and teenager, and then they stop growing. They stay the same size your whole adult life, unless you have kidney failure or something that forces them to grow and work harder. But they don't grow, they stay the same size, while patients who have hyperplasia continually, without an inciting reason like kidney failure, continue to have glands that grow. And all we're doing is decreasing the size, the number of parathyroid cells in that person's body, because they're going to continue to grow, and hoping the growth rate of the remaining parathyroid is slow enough where it doesn't catch up with you while you're alive, right? Or if it does, we go in there and hopefully just cut a portion of that remaining parathyroid and leave a portion behind and buy you some more time, right? So in my mind, the surgery that you should have is finding which one is the larger one through scans, taking it out and looking at PTH levels, right? Minimizing the risk, not going on both sides, going on one side and treating, okay? And that's the strategy I would take. And I really don't agree with your doctor. There is increased risk to the vocal cord nerves, but what you have to balance out is how much are your symptoms affecting your life? Compare it to the risks that they're talking about. And you know, I think you need a doctor who really is compassionate about your symptoms, right? It empathizes with what you're going through, so that they can try to help you without worrying about being sued, right? Because that unfortunately is affecting how we as surgeons, the doctors, act, you know, and that's the problem, part of the problem, I'd say, you know. Part of the problem is experience of the surgeon. Part of the problem is what problems they've had, what problems they face, what you know, if they've had tough cases and have had patients get vocal cord paralysis of 1 or 2 or 3, and you know, past their threshold of being able to tolerate, then they're going to become super conservative, you know, and that's just human nature, also. And so let me get to your questions. So my question is, should I give up until my calcium is high? Absolutely not. You have symptoms, you need to treat it. Also, The doctor did an ultrasound and was able to visualize both paras, left, one slightly larger than the other, so they're both on the left side, okay? But small. Can normal parathyroids be found through ultrasound? Exceedingly rarely do you see a normal parathyroid on an ultrasound. So if he sees it, I'd say encourage him to do a surgery and remove the one parathyroid that's enlarged. The good fortune you have is both of the remaining parathyroids are on the same side, on the left side. So you have no risk of injury to the vocal cord nerve on the right, right? That's great. And I would go in there, take the larger one out, find the nerve. I mean, revision parathyroid surgery is harder, but it's not impossible. We do it all the time. You've had a few people on this chain of emails that have had it. You know, it's very doable. So if you have symptoms, I encourage you to address it. Life is hard enough as it is. There's no reason to have the hardship of parathyroid added to it. Dolores Tucker McNeil. I'm new to this group. I have hyperparathyroidism since 2016. My level ranged from 130 to 178 and calcium 9.2. Ultrasounds are normal. Osteoporosis, kidney stones. I also have terrible bone and joint pain as well as multiple thyroid nodules with biopsies. The biopsies are happening every 3 months. Can the hyperparathyroidism cause the multi-nodules? No, they don't. They just, parathyroids and thyroids just happen to be next to each other and have similar names, but that's about it. They have nothing else in common besides the blood vessel that feeds them, right? Can the hyperparathyroidism cause, I also had a gastric sleeve in 2011. My weight came back and I followed the plan. Help. I haven't seen the endocrinologist, only the nurse practitioner. I received a call regarding my labs from August a week ago, and they said the nurse would call me to set up an appointment to discuss surgery. Any advice? First, Dolores, patients who have gastric surgery may have absorption issues with vitamin D. It happens more with gastric bypass than a sleeve, but I think it potentially can occur there too. And so you have to see what your vitamin Ds are, and if they are low, try to correct them and see what happens to your numbers. Because patients who have normal calcium, especially low normal calciums and high PTH levels, can potentially have secondary hyperparathyroidism due to low vitamin D levels, right? And so that's really well worth investigating. So look at that and replace the vitamin D first before going into surgery. So that would be the first advice. And then in the meanwhile, you can do the imaging studies and see. I mean, you can do an ultrasound to see if they see an enlarged parathyroid. Because if they do, then that also probably means that you don't have secondary hyperparathyroidism and you have an adenoma. And you may want to seek treatment sooner. So I mean, I would follow it on both fronts. Get imaging studies and replace any deficiency, especially in the vitamin D system, and see how that does for you. And obviously, if you have secondary hyperparathyroidism, which is what I hope you have, then surgery won't help you in any way, shape, or form. Then you can just correct it with supplementation. Jimmy Threat. The question is in reference to patients that have been diagnosed with recurrent hyperparathyroidism by an endocrinologist years after their first surgery. How long should a patient wait before they are referred to a surgeon since it's a reoperation? It all depends on the impact on your body. If you're having symptoms and your quality of life is different, then you should seek treatment. And it's a reoperation, you should seek treatment from someone who has significant experience. Do calcium scores need to be above a certain level, greater than 11? Absolutely not. That's just nonsense. Calcium levels, normal calcemic hyperparathyroid patients suffer equally as much as hypercalcemic. So, no, the number is not meaningful. The fact that you have hyperparathyroidism, your PTH and calcium are not following a suppressive relationship is what gives you the diagnosis, and the treatment should be sought if you have symptoms that are affecting your life. Do tangible, measurable complications need to develop again? No, I don't think so. I mean, they may tell you that, but I'm not a believer that you have to wait to get a stone or a bone fracture before you do surgery. I think you should prevent it, especially if you're younger. Or if you're older, but you're otherwise healthy and robust and an active human being, right? You want to be that person again. So you should take action. What about other complications that can't be measured? Symptoms like anxiety, would that be a factor? Well, if you had surgery and you had improvement in your anxiety level, right? And you felt that the quality of your life improved, then you already know what this surgery can do for you, right? Forget about the international guidelines and what the surgeon says. You are the only important factor. So if you know your anxiety will get better with treatment of hyperparathyroidism, there's no better litmus test than that. So that's what I would go with what you know to be true. So yes, I definitely think that's a factor. Best of luck, Jimmy. Be your own advocate. All right. Don't let these guidelines control your decision. Let what you feel about your body control that. That's really the most important thing. A message I can pass along. Joan Beckett. I've been tested for MEN1 twice, both negative, and after suffering from hyperparathyroidism for many years, but the surgeon I recently saw at Bart's in London states she won't operate because she believes one day I will test positive. I have no idea why testing positive or negative would have an impact on you seeking treatment. Right? First, depends on the MEN1 testing that you do. So if they're specifically testing for known mutations for MEN1, you may have an unusual mutations and not be detected, right? And I think that's probably what your surgeon is saying. But two, if you have MEN1, which means that they should be looking for pancreatic tumor or pituitary tumors, and if you have anything of the sorts, right, forget about the MEN testing, you probably have something going on, right? And if you have hyperparathyroidism, with or without MEN, you need treatment, right? Now, the MEN patients tend to have a more likeliness to have hyperplasia. That's what they get. They get hyperplasia. MEN1s do specifically. And so what it would do for your surgeon is make it more likely to do a 4-gland exploration. Having said that, you're uncertain about your MEN status, let the imaging studies guide your surgeon as if you have 1 gland that's abnormal or more, and intraoperative PTH testing also to guide the extent of surgery that you're going to have. So I think if you're having symptoms, don't wait. Treat. This waiting and watching thing, it just really irritates me, right? Waiting and watching is okay for a doctor because they don't have symptoms. Not for a patient who's being affected and is having symptoms, you know? It just makes no sense. All right, Jackie Booth. Hi, Jackie. My recent surgery notes histology show that one right inferior hyperciliary gland was removed, right? Along with the right-sided thyroid due to cancer. But they also auto-transplanted the right superior gland. What question can I ask when I go to clinic as to why they did this? Well, let me read the rest. I've not been given a straight answer yet as to whether they did look for all 4 glands or if they simply didn't look on the left. There's no mention of my left gland on reports. One trainee said they couldn't find them on the left but looked flustered. They've always insisted I do not have hyperparathyroidism and only agreed to operate when they found the cancer. Wow. Hard to answer. But listen, look at your numbers, right? Look at your calcium, PTH, and vitamin levels before surgery and now after surgery. If your numbers have corrected and are now following a suppressive relationship, then you had an adenoma, fortunately, and nothing else, and you're good. You don't need to worry about it so much. Now, why would they auto-transplant? Well, if they looked at the right side, they had a small cancer there, so taking out only half of the thyroid was adequate enough to treat that cancer. Great. And if during surgery they see one parathyroid that is enlarged, right? The right lower one. They take it out, they're like, okay, so he has labs that can mean hyperparathyroidism. And then the other parathyroid, the superior parathyroid, which is stuck to the backside of the thyroid, as they're removing the thyroid, they see that that parathyroid doesn't have enough blood vessels feeding it anymore and is not surviving. They would take it, chop it into little pieces, and put it back into the muscle because it would appear to be a normal, healthy parathyroid. That would be the right choice. That would be the right decision. Now, I'm not sure if they explored the other side or not, and at this point, it's neither here nor there because the surgery's done. What you need to know is if your numbers are normal. If your numbers have normalized and you feel better, then it doesn't really matter if they explored it or not. Unless you ever need to have surgery again on the left side. That's the only time it would matter. If you don't, if your numbers have normalized, you feel better, you don't have hyperparathyroidism anymore, then you're okay. You know, I don't think you need to stress about that at all. I mean, it's not right that your surgeon is not giving you a clear answer, and I personally would kind of like sit him down and say, hey, I really need to know what you did during the surgery, and I need to go over my numbers for hyperparathyroidism before and after surgery, because you probably will do them a favor, because if they actually did treat your hyperparathyroidism and cured you, they need to learn from their experience now that to listen to people like yourself and treat. Anyways, good luck. Last question in the email series. All right. Hi, Rachel Goodman. Thank you so much for all you do. My pleasure, Rachel. For a patient who has had bilateral exploration, whose pathology report says 2 of 4 parathyroids were ectopic in thymus and biopsy. If patient is later diagnosed with MEM where it's recommended to remove the thymus during the initial surgery, can thymus later be successfully removed? Absolutely, given the scar tissue created from the initial parathyroid surgery above. Yes, Rachel. You can have, it's all a question of what you have left behind. So you said that the thymus was biopsied, but did they remove the 2 parathyroids in the thymus, or did they just biopsy them and leave them behind? First question. What's the status of the 2 other remaining parathyroids? Did they remove any of those? Or did they touch them? Did they see them? Did they find them? Did they do anything to them? Is your hyperparathyroidism corrected? Or where do you stand? All these questions are important, because let's say they biopsied the 2 parathyroids in your thymus and they removed the other 2 parathyroids that were superior. Now, if you do a thymectomy now, you'll be left with no parathyroids, So I think there's a lot of important questions there. But can a revision thymus surgery be done? Absolutely. Absolutely, it can be done. Again, it requires experience. Fortunately, the thymus is usually above the level of the recurrent laryngeal nerves, so the risk to the nerves is a lot less, more minimal. There is a risk, and I would use a monitored breathing tube to monitor the vocal cord and the nerves, but it is doable, for sure. All right, let me see. There's a few more questions that came in as we were speaking. Let me see if I can see them. What is the longest amount of time that it's taken to see any improvement for one of your patients? 2 years. I've had patients who at about 2 years felt finally better. Good questions, Leanne Schroeder. Dinke Smith. Dienek Smith. Sorry, I massacred your name. Dienek, the messages that you're sending through are partial, so I can't see the whole message, unfortunately. Yeah, I think Dienek and Leanne Schroeder are having a conversation, so I can't see the full conversation. Sorry, ladies. But if you send me an email or a message through Facebook, so I can answer any specific questions you guys may have later. All, I'm sorry, everyone. All the other ones are just truncated messages. So I see the first 3 lines of the message, but not the entire message. So I can't really. So message me through Facebook, again through this group, and I will try to answer your questions. Okay. Hope you guys have a wonderful day. I'm sorry I can't see your questions. Actually, Catherine Brooks just sent a message. She says, curious, when having the operation, if 3 glands have tumors, should the 4th gland be removed? Absolutely not. Catherine, like, the 4th gland is your only remaining gland, and so you need it to function. So, please keep it. All right. It's truly an honor to be able to do these sessions and answer your questions. Hopefully I've helped you guys and guided you in the right direction. I try my best and I do my best, and I know I get emotional and passionate about certain things, but there it is. Have a lovely month. I look forward to talking to you guys again and hopefully helping. Bye now.